Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hi, everyone, and welcome to the CodeCast podcast today. I'm not sure how your weather is shaping up this week, but in Southern California, we have had the coldest weather I think I've remembered in a really long time. I'm ready for some sun. It's raining actually here again in Southern California, and this week we actually woke up to some temperatures in the 30s. Yes, we're whining, because if I see 30s, I want to see snow, but it is definitely crazy. And I know many of you now know that the Patriots won the Super Bowl, and I'm sure most of you were thinking about me on that day, thinking, Terry is not happy. Well, you would be right. I am in a period of mourning right now, but what can you do? So I'm ready for baseball season. I'm kind of footballed out right now. Even there's some new, arena type football thing out there. So I'm going to move on from that and hopefully enjoy the little bit of a break I have from that and get into a topic today that actually is more of a theme. And it's a segment I wanted to do called You Be the Expert. And what I actually mean by that is I want to give you the insight, the tools, and really the clinical and coding language and the power to show that you are the expert and how to confidently project that persona in your everyday work. I want to really just look at, one of the things that sells you and keeps your job and gives you job security is your credibility. And I want to empower you as a healthcare professional to be that expert. So let me explain how you can do this. So let's say someone in your practice, a doctor or a staff member, wants to find out the best way to code for migraine headaches. So here's how to tackle that scenario and how you can, again, be the expert. So the question would be, let's say someone comes to you in your office and says, I'm a bit puzzled by the ICD-10 codes for migraine headaches. Specifically, a couple of terms in the code descriptors confuse me. For diagnosis purposes, what is an intractable migraine? And also, what is status migrainosis? So these are some clinical terms that you're going to want to know if you're going to be an expert on the topic. And so basically, you're going to say to this person, and this is how you're going to approach it, you were right to be concerned about the definitions of intractable and status migrainosis. Without knowing what these terms mean in I-10, you might miscode them. So let's take a look. So intractable versus non-intractable. And talk to the person like you're having a conversation and not dictating to them, this is the way you do it. Basically, to be an expert, you want to make that person feel comfortable. That's what I pride myself on, especially not just in the CodeCast, but the webinars I do and anything that I present live. You want to be approachable. So you're talking to them, basically like you're having a conversation. So you'd say in many migraine headache coding situations, you need to decide whether a migraine is intractable, such as in code G43.411, and that's hemiplegic migraine, intractable with status migrainosis, or non-intractable, such as in G43.501, persistent migraine, aura, without cerebral infarction, not intractable with status migrainosis. So for diagnosis purposes, an intractable migraine is a headache that won't relent despite several attempts to end it by the provider and the patient. And then you want to say some of the potential symptoms that might indicate a patient with an intractable migraine include autonomic nervous system symptoms. And that just means automatically they're going to have nausea, vomiting, and possibly sensitivity to light and or sound. And so after deciding whether or not migraine is intractable, you can detect your attention to the fifth character of the ICD-10 code. And I would have your book out at this point just to show them what you're looking at. So you would go to that code G43.51 and say if the code has a 1 in the fifth slot, it represents an intractable headache. Persistent migraine, aura without cerebral infarction, intractable. If the code has a 0 for a fifth character, the migraine's not intractable. And so, for example, G43.50, and then you're going to need an extra digit. And then you want to give them clues. Say, to submit an accurate migraine headache diagnosis, you also need to know what ICD-10 considers status migrainosis. So for diagnosis purposes, status migrainosis represents a severe migraine lasting 72 hours or more with possible severe dehydration and or electrolyte depletion caused by nausea and vomiting. And then give them clues. Again, say to indicate whether a migraine includes status migrainosus, look to the sixth character of the ICD-10 code. If the code has a 1 in the sixth spot, the code is for a patient with status migrainosus. So for example, G43.701, chronic migraine with aura not intractable with status migrainosus. If the code has a 9 in the last character, the patient doesn't have status migrainosus. So an example, G43.709 without status migrainosus. So the symptoms of status migrainosus are similar to symptoms of a typical migraine. A migraine with accompanying status migrainosus, however, might also include sensation of sparkling lights or other vision changes. That's what the aura means. Nausea and vomiting, difficulty thinking properly. But bottom line, just say, do this. If you see any of the above features in the encounter notes describing a patient's migraine headache, be ready to check if a status migrainosus diagnosis is appropriate, or I should say more appropriate than the other. This came up to me the other day with a comment on new versus established patient. And you want to give the information that you know, and then basically they're looking for a tidbit. Just give me a quick hit on what am I looking for? And I said, if there was ever a face-to-face in the last 3 years, you might have an established patient visit. Just always keep in mind that face-to-face. So this is similar here. When you're the expert, you can come off with things and basically you're saying, okay, this is what you're looking for. And as long as you can do that, you have some good credibility with that person you're speaking with. So my next example of you being the expert actually talks about boosting your bottom line and bringing to the attention to maybe an administrator or a manager or even a physician, if they're the ones that run the practice, something that you've been reading upon, that's something that you found. And this can really speak to how you sometimes lose money within your practice. So think about this. So the use of, or I should say, when a practice discards drugs or biologicals, and the physician doesn't need to treat the patient, they use part of the medicine and there's waste, and that happens quite a bit. And what you want to really look at here is, what do we do with that? And so many practices, it's amazing to me because when I give live seminars or I'm giving a webinar and I talk about this, a lot of practices look at me like, we can get paid for things we didn't use? Yes, you can. First thing you want to know is, as of January 1st, 2017, there was a modifier that came out from Medicare called the JW modifier. And it basically means drug amounts discarded, not administered to any patient. Practices are hemorrhaging cash due to unused drugs or biologicals. So when a provider treats a patient with a single-use vial of a drug and doesn't use the entire portion, the rest of the doses just usually get thrown away. But with the modifier JW, you will be able to report the entire vial supply in certain situations. So not in every situation, but in certain situations. So let's take a look at that. And this is what part of it makes you the expert. So there was a change release that Medicare put out, and it was on a transmittal, and it was R3508. And it basically said, here are some rules for the JW modifier, and effective, it was July 1st, 2016, but they moved it to January 1st, 2017. For claims for discarded or biological amount not administered to any patient shall be submitted with the JW modifier. However, this will allow for payment for an amount of discarded drug in certain situations. So let's say that your provider treats a patient with 95 units of a single unit or single use 100-unit vial of a drug and discards the remaining 5 units. So according to Medicare, you would code the 95 units of the drug on one line and the remaining units, 5 remaining units on another line with a JW modifier. Now, you have to be careful only because the CR does not open the door to use the JW on all discarded biological situations. So what they're looking at is that they do prohibit the coding of the discarded drug administered is less than the billing unit. So for example, 1 billing unit for a drug is equal to 10 milligrams of the drug in a single-use vial. So a 7 milligram dose is administered to a patient, while 3 milligrams of the remaining drug is discarded. The 7 milligram dose is billed using 1 billing unit that represents the 10 milligrams on a single line item. So the single line item of 1 unit would be processed for a payment of the total 10 milligram of drug administered and discarded. Billing another unit on a separate line item with a JW modifier for the 3 milligrams would not be permitted because it would result in overpayment. So you have to know when it's permitted. And Medicare also makes it clear that the JW modifier is only for single-use vial or packaged drugs and biologicals. So this is also in part of the Chapter 17 of the Medicare Claims Processing Manual, where it says multi-use vials are not subject to payment of discarded drugs. So you really want to make sure that when you're reading the transmittal, you're understanding what they're talking about when it comes to this discarded drug and this information. But this can be a huge deal. So it can make sure that you are not losing money, and again, make you the expert in how to capture some waste when it comes financially from things that you're actually spending out of pocket. So let's take a minute for our coding question today. And one of my Coding Corner members asked this week, and they're from South Carolina. There is a note from my physician saying that he does an aspiration thrombectomy with every coronary intervention, and he should be able to code for it. The only code I found was an add-on code 92973. Is this appropriate for that service? Okay, so you'll find that payers usually considered coronary aspiration thrombectomy to be part of the percutaneous coronary intervention, or the acronym PCI, such as angioplasty or stenting. So you should not report a separate code for aspiration thrombectomy when performed with a stent or an angioplasty or any intervention. To report an aspiration thrombectomy performed on its own without intervention, that's just going to be an unlisted code, probably the 93799. But the one thing that you want to look at on the 92973, and make sure you're always reading the language, which will probably answer some of your questions. It says percutaneous transluminal coronary thrombectomy mechanical, and then it tells you to list separately in addition to the primary code. This is specific to mechanical thrombectomy, meaning that the service involves using a mechanical device that breaks the thrombus, which is the blood clot, into fragments, then removes the clot by the apparatus. So you might have seen an angiojet or an exciser. Those are some examples of this mechanical device. It also takes a ton of time to set that up in the procedure room. Documentation may include a reference to a foot pedal and motor as well. An aspiration catheter sucks out the clot without the fragmentation step. So names associated with aspiration catheters include Fetch, Diver, Export, and Pronto catheters. So make sure you base your coding on the procedure described, not on certain language that maybe sounds similar. Otherwise, it can result in an overcoding, and then they'll ask for money back later. Today's coding question was brought to you by the California State Chapter of the American College of Cardiology, working to prevent cardiovascular disease and ensure quality care in California. www.caacc.org. Now, to continue with You Be the Expert, I wanted to briefly turn to collections and appeals, or really what you now hear as revenue cycle management. But I want to focus on the back end of the claim. For me, that's appeals and collections. I think sometimes the fancy acronym RCM and the wording or the change in revenue cycle management, that means from the time the patient walks in until they leave, which is absolutely important. I've written books on the topic. But I want to focus on looking at that denial and when you're not sure what to do with it. And I believe that your successful appeal comes in the form of communication. So many people, and you're busy, have to do stacks on their desk that just, oh my gosh, they hobble your productivity. But if your to-do stack is full of denials and you've been meaning to get to the appeal, hopefully these tips will inspire you to tackle it. And then you won't have to worry about or have anxiety about, oh my gosh, I've got a stack there. Give payers what they want. This is my first tip for this. It's easy to miscommunicate if you are speaking a different language. Make sure you understand exactly what the payer requires and what you want as well, and then format your appeal letter and claim accordingly. There's a funny story I just want to mention that I heard recently, and I just thought it was kind of humorous. So this teacher basically told her students that she wanted them to do a free write for 2 minutes and to write down how to make a peanut butter and jelly sandwich. And I thought, okay. And she said, go. And they're just like, wait. She's like, no, just write it down. So she took all of these papers from these students and then decided to go home and make a video of it. And some of the papers would say First, put jelly on the bread. Okay, well, she basically took a loaf of bread and put a jar of jelly on the loaf and said, "Is this what you meant?" And the kids laughed. A couple of more said, "Put between 2 pieces of bread peanut butter." So she took the jar of peanut butter and put it between 2 pieces of bread. I think you see where I'm going with this. Another one said, "Take the bread out of the cupboard." So she opened a cupboard door and said, "Where's my bread?" So she was trying to make a point that details and communication are key. When she finally got to the paper of the one student who said, "Take the bread I bought yesterday out of the cupboard I put it in, open the bread, take 2 pieces out, and put those 2 pieces flat on the counter. Take your knife out of the drawer, open up the peanut butter jar, take out a scoop, and spread it evenly on the bread. Then wipe off the knife on the peanut butter jar edge and go to the jelly jar. Open the jelly jar and open it," and so on. And so you know where I'm going with this. That kind of details can really help when you are writing appeals and collections. And you want to be so specific that the person that's reading your appeal letter knows what you mean, knows where to go, and understands that you are the expert. We also want to look at the remarks codes on the explanation of benefits and address those specific edits. You don't want to hand them back the same medical record because they're just going to deny it again. So you want to address the remarks codes, the missing information, any bundled services, which are common reason, I should say, for denied claims. And then payers often look for additional diagnostic or clinical information to support why they're not paying for something. And then also watch out for any kind of bundling. Make sure you understand what is bundled, meaning inclusive of the service. And then utilize regulations and also maybe some citations for support. Citing proof that you're playing within the rules protects you and can boost your appeal. Bottom line is, I want to make sure that you are using regulatory information or citing CPT language, and that's one of the best ways to fight claims. It tells you directly what you can and can't do, and it also basically gives you the language to use within your appeal letter. And then you also may forget that the patient is central to the whole claim denial appeal process. So if you stay on top of your denials and appeals, you have more time to involve the patient if you have to. Also, if you have mid-level providers in your practice, a lot of your mid-level providers can give you that clinical piece if you don't have a nursing background that maybe you don't have as a coder or a biller or a collector. And they're usually more open or accessible, I should say, and have a little bit more time to give you some information that can help you with some language. And also know your contractual rights, figuring out who is reviewing the claim and issuing the denial. If the reviewer's credentials don't necessarily suggest a knowledge base or a background that are qualifying to understand the procedure or encounter in question, then you can demand a peer review. I've done that so many times. Many denial letters are signed by nurse case managers. If your practice is a specialty practice or your clinicians perform surgery, a nurse may not have the expertise really to understand the nuance of the encounter described by your claim. So here's one that came up recently for an office, actually, just this week. And they said, they're a Coding Corner client. This is what I do for you if you are a Coding Corner client of mine. So she said, we're having a problem. And actually, this office is an office that I code for. So they send me all of their cath and peripheral reports, and we code pretty much all of their procedures. And so I'm familiar with a lot of their cases as well. But they got a letter from a particular Medicare payer, and I think it was a Medicare Advantage plan. And they got a letter from a nurse that said she was the director of payment integrity. And what they are doing is they were asking back 3 patients for their heart cath when billed with a stent. And so I said, well, that doesn't make sense. Let's go back and take a look at the op report and then take a look and see if the physician worded it correctly so that we can fight this appeal. So here's my letter. So, dear Ms. Letter sender, please find enclosed a copy of our procedure report for the above named patient. This report reflects services that included a cardiac catheterization and a percutaneous coronary intervention. If you review page 1 of 4 of the physician's report, the first paragraph gives medical necessity for the heart cath with, and I quoted, symptoms of chest pain and abnormal heart cath demonstrating ischemia, Due to this presentation, the physician determined a cardiac cath was in order to determine the extent of the heart disease and what potential further treatment may be necessary. The patient signed a consent allowing for this diagnostic test that also stated should therapeutic intervention be necessary, they would allow going forward. Okay. Then I went on to say on page 2 of 4, after the cardiac cath was performed, and this was great language by the physician, the results confirmed, and I quote, single vessel disease, and due to the severity and nature of the ischemia, a 95% lesion in the right coronary artery, it was recommended, and the physician proceeded with a percutaneous coronary intervention of the right coronary artery. Then I went on to say the procedure was successful as stated on the bottom of the last paragraph on page 2 of 4, taking the 95% stenosis down to 0. Based on this report and the clear documentation that supports medical necessity of the diagnostic test that led to the intervention, this request for a refund is incorrect. We respectfully ask that you reconsider your decision to request a refund for this cardiac cath. The PCI, and I spelled out what that was determined to be the appropriate treatment for this diseased vessel only after the results of the cardiac cath was reviewed. If you review pages 658 to 659 of the 2019 CPT Professional Edition, see attached, it is clear that diagnostic angiography, also known as a cardiac cath, performed at the same time of a coronary interventional procedure may be separately reported if 1. No prior catheter-based coronary angiography study is available and a full diagnostic study is performed and the decision to intervene is based on that diagnostic angiography. We have met these conditions in the attached procedural documentation. As such, the cardiac cath 9345826 modifier is a payable service on the same date as the intervention code 92928. Thank you for your consideration in this matter. We hope to hear from you soon. So here, basically, I spelled it out for them, saying that you're saying it's not billable service, that it's inclusive of the procedure, and CPT is saying absolutely not. And also, it's not part of the contract. So they're basically just picking and choosing. And the reason is because in cardiology, if you're part of that specialty, there's a lot of cath possibles, and I would say almost 80 to 85% of all heart caths lead to an intervention. So I can absolutely understand how a payer might think that it's more incidental to or set up angiography, but so they're spot checking. So we had to basically go in and take a look at the report, make sure the language within the report was appropriate that showed one service led to another service, and then spell it out for them as part of what I like to call the regulation, the CPT language. This is an authoritative reference because that's where we get our codes, we also have the AMA sticker on front, American Medical Association, showing that I know what I'm talking about. So when I'm trying to again say, as far as you be the expert, this is what makes you the expert. Bringing forth information that shows that not only do you have credibility, you know where to find your information, you know how to prove and support what your physician is doing, and making sure that when you get into that claim denial, get into trying to make sure that you get to keep your money and not have to send it back, that you are the expert, that you know where you're going with that. If you want to continue with some of this, I do have that collection and appeals webinar that I want to remind you of on Thursday, February 28th. You can go to my website at terryfletcher.net and you'll see it up on the website. So make sure that you click on live audio conferences and it'll be up there. But we'll give you more letters, more information, and it's multi-specialty. It's not just cardiology. So you can really know how to be an expert in the field on many things that you're doing within your practice. And hopefully this will just empower you to be that healthcare professional I know you can be. So my personal challenge this week, and actually it's going to sound a little bit like a professional challenge, but it's both. One of the things that I need is that I need to feed my connection with people. Being someone that, even though I have a satellite office now, and I moved my office out of my home office because of my expansion, I'm still working alone and even when I'm traveling, I only see you on the road. I love the feedback I get from you guys. Believe me, it makes me feel less isolated. And for those of you remote coders, I'm sure you can relate to this as well. But I would like to challenge you for 2019 and really try to get out to a professional meeting. go on the AAPC website and find where they're having a chapter meeting, or go on some kind of they call them Eventbrites, and those are networking events or happy hours, even with friends. And, just take an hour for yourself. And I have what I call a WA breakfast, the Women in Healthcare Administrators of Southern California. I'm one of their members, and I'm on the events committee. And I do a breakfast, which is called a executive breakfast, once a year. We're moving it up to twice a year. I have one on February 27th in Laguna Hills, and I'm hosting it. And we only allow 10 women. And it's not just for women. I mean, we are a women organization, but it's for anybody who really wants to come and just chat and network and let us know what you're doing, exchange business cards, and, have some breakfast with us. And it's at 7:00 in the morning. You can still go to work after it. Also, in honor of International Women's Day on March 8th, see what you can find out there. See what networking event is out there. I know I'm hosting a wine and cheese networking happy hour at my local wine bar on March 7th. And I did it last year, and oh my gosh, we had almost 80 people where we were expecting 40. So it was very fun. But find events like this so that you can mix with your peers, meet people maybe you have not had the opportunity to meet. And again, if you're a remote coder or an HIM professional, or someone who feels that, you're going to your job every single day, surrounded with people you love, of course, but you want to just get out and, meet somebody that maybe you didn't have an opportunity to meet before. And check it out. Check out what the venue is on Yelp. Find out, how comfortable it is, how the seating is, how the parking is. And just really try to do that. I really challenge you to do that. And then email me or, get me on social media and let me know how it's going. I'd love to hear, what everybody says about that, and if you actually got out and did that. So hopefully that's something that you can really find for yourself, not just this month, but hopefully sometime this year. So everyone, go ahead and make it a great day. And until next week, thanks for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1, or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.